name is Dr. Elizabeth Itotia, and I'm a proud pioneer radio pharmacist in the country, and I work at KU Referral. Sometime back, like one and a half months ago, Dr. Daniela emailed me, and the email read, "Dear Dr. Itotia, I am writing to request you to speak on the nexus between training and practice while drawing from your own experiences." I was not sure I was going to make for this conference because of work commitments, but that was not even my first assignment. My first assignment from that email was to Google what was the meaning of the word nexus. I had zero idea what she meant, so that statement made zero sense to me. So thanks, Dr. Daniela, because I also learned a new word, and because I know in this crowd there are people who do not know what nexus means. It means the connection, the link, the relationship. So the next time you're speaking to someone and you want to say the relationship between something, just say the nexus between something, and you give them a bit of stress, they go and Google. I was supposed to draw this from my own experiences, so I'm going to start by giving a bit of my academic journey, and then from there, I am going to use the SWOT analysis. Our boss, Dr. Minor, normally tells us to use the SWOT analysis a lot of times. So initially it used to be hard, but with experience and his guidance, it has become easier. So I actually borrowed the approach from him. I'm going to use the SWOT analysis to see what is it that I felt from my training. I was really ready. What were the strengths? And then I'm also going to see what are the weaknesses. And of course, from those weaknesses, I'm going to discuss the opportunities and the threats that face our practice as pharmacists. For my undergraduates, I was at the University of Nairobi, and as is the norm, at the 5th year, we are supposed to submit a dissertation. So when the dissertation list came out, if you studied at University of Nairobi, you know Professor Itotia. So when the dissertation supervision list came out, by that time, I considered it unfortunate. So I was unfortunate enough to be allocated Professor Itotia as my professor. And Professor Itotia was known to be, or is still known to be, very strict, very thorough. So I knew I was not going to have an easy time with my dissertation. But and unfortunate enough that time, Prof. Itotia had been unwell, or is still unwell. So she was not able to come to school as often as she was supposed to. So the agreement between myself and her was that I should be going to her place so that we discuss my dissertations, do corrections. That time she could not even use the computer, so I had to print hard copies and deliver them to her. Fortunate enough, depending on how you look at it, there was a strike at the University of Nairobi. And so I had 4 clean months to just do the dissertation. So I was done with dissertation before even the 5th year of class started, because Itotia would really push me. That is not the point of the story. The point of the story is that in the middle of, after now I had finished my dissertation, Prof. Itotia approached me and told me, and I was at her place, we were sitting under a tree, and then she told me, Itotia, I see something in you. And I think that you should graduate as valedictorian. That time, to be honest, I did not care whether I graduated as valedictorian or barely with a 50+1. All I wanted was just to finish that B Pharm and become a pharmacist. It had become too much. But when she told me that, I went home and I asked myself, what is it that she has seen in me that I do not see in myself? And after like 2 other months, Dr. Njogu said the same thing to me, that Itotia, you should graduate as valedictorian. I was, yes, doing well in academics, but I was not always the best student. So why is it that they were selecting me? Those were the things that were going through my head. And now, because now they started making me not just want to graduate, but graduate as valedictorian. And true to their word, I actually did graduate as valedictorian. Oh, wow, thank you. After that, now for my internship, now after I finished school, Itotia still came to me and told me, now I am your self-nominated mentor. Whether you like it or not, I am going to mentor you. Of course, the idea was welcome because I did not have a formal mentor. Then she told me, now because you have graduated as valedictorian, now, and you know that it is not as easy as it used to be for pharmacists. So I need you to, during internship, to actually research and decide what it is that you want to do after you finish your internship. And that time when I was in my undergraduate, I always thought I'd do a master's in pharmaceutical chemistry because I was performing well in pharmaceutical chemistry. She gave me a whole lot of things that pharmacists can do. Of course, the normal that we all know. And then there was what now was outside pharmacy, and radiopharmacy was actually one of them. She had, by that time, she happened to be the IEA counterpart for the country. And she was the one in charge of the radiopharmacy program for Kenya. So she told me there's also this course called radiopharmacy, this, and this. And that's when I started my research in radiopharmacy. Of course, I was researching around many things. And that's where my interest for radiopharmacy came from. And that's how I am a radiopharmacist today, because she guided me. I liked radiopharmacy. She told me which kind of opportunities I should apply for to actually know, because she was in the field, she knew it. And I applied for the opportunities, and I was lucky enough to actually get the scholarship for the IEA to study radiopharmacy. So why have I given that story? I am going to start with mentorship. I said I'll discuss the strengths, the weaknesses, our opportunities, and the threats. Prof. Itotia saw something in me that I was not seeing in myself. By that time, to her, and I still believe I am, to her, I was a young girl who needed mentorship. She saw something in me and she decided to hold my hand. So my question to you, who is seated in the audience, is because in this room, we have directors, we have CEOs, we have medsups. So my question to you is, to the young pharmacists who are outside there, because the situation is bad, what is it that you're doing in your position to actually elevate the position of that pharmacist? You do not need to offer them a job. Clearly, Prof. Itotia did not offer me a job, but you can offer guidance, you can offer mentorship, you can show them the way, because you have been in this field for longer. You sit in boards where decisions are made, you sit in positions of power where you can actually say that this position of a pharmacist cannot actually be substituted. That in this place, let us give a pharmacist a chance. That in the government says for this kind of regulation, we actually must have a pharmacist in a level 3 or a level 4 facility. So as a policymaker, because we have big people seated in this audience, what is it that you're doing to actually elevate the practice of our pharmacists? That was the basis of that story. And from my training, starting with the strengths, I did my internship at Autosterile and KNH and Ram Pharmacy. So when I went to KNH, I felt, and I stand guided on this because it might sound a bit political, I felt like I had a lot of theoretical background. If you could pick any drug and ask me anything about that drug, I would answer very well. I'll tell you everything. But when it comes to the practical aspect of it, for example, let's take ceftriaxone, for example. I knew what ceftriaxone is, which class of antibiotics it falls. But ask me what is the strength of ceftriaxone, how do we dose it, how do we source it, what's the supply chain involved in this drug? I had zero idea. And so I feel like in our practice, and the major gap that I feel is that there's a very big disconnect for pharmacists between the training that you're getting and the practical aspects that is there. If we compare it with medics, for example, medics start their clinical rotations as early as probably they join med school, or dentists, for example. So by the time this dentist is released to practice at internship level, you can tell the difference between the pharmacist and the dentist, even in the level of confidence that they show, even when they're dealing with the patient. You can find that a medic, yes, there are things we learn on the job, of course, but you can find that a medic would comfortably by week 2 be left to run a facility alone. But I can guarantee you we cannot receive an intern and let them run our pharmacy alone. You also find that these people believe we do pharmacology, pharmaceutics for more years than they do. So they will actually come and find me, a naive intern there, and ask me, so Dr. Itotia, how do we dose ceftriaxone? Because I have done pharmacology for 3 years. You know, maybe daktari, drug index or something, because, you know, we are both as green. But it shouldn't be like that, because if I went to them with a medical question, they probably would not refer me to the dictionary. So what is it that we can do? And probably this hypothetical question, something we should think about. What is it that we can do to actually change how we are training pharmacists, to actually change, to make us more ready? The environment is very harsh for us right now. To actually make us more ready that when we are going into the markets, we are showing more confidence or even equal confidence to our counterparts, to our medics and to our dentists. The other weakness that I feel we should also address, either at training level or start thinking of short courses or CPDs or CMEs, is there's a very big disconnect between our training and practice. And what do I mean? Some very critical aspects of training are missing in our undergraduate training. For example, we all know that regulatory affairs or QA manager is a pharmacist role. It is actually in the PPB that if you are to be the QA manager of any institution, you actually have to be a pharmacist. You have to have a pharmacist license. But by the time you're finishing your undergraduate, how many of us clearly know what an electronic technical document is, or SRA, as we were learning yesterday? Not many of us. There's a time after internship, there was a whole 8 months of tarmacking. So there's one time, Bayer, East Africa, I was very ambitious. So Bayer, East Africa advertised for the regulatory affairs pharmacist for East, Middle, and Central Africa. Itotia decided this is a job for me. And I've just come from internship. So I applied. And then I don't know what Bayer saw in my CV. They actually called me for the interview. So when I went for the interview, so the interview was made up of like 8 people, senior people at Bayer, because now they want to hire their regulatory affairs pharmacists to represent them in the whole region. I am telling you, they asked me questions. I have never, ever sweat in an interview, and it was showing. My whole shirt was wet. They were asking me question, pass, ask, pass, ask, pass. And you know, I had actually asked other regulatory affairs pharmacists there, so they had I had some information on dossiers, the parts of the dossier, but that's not what they were interested in. That was actually part of the introduction. How are you, Dr. Itotia? So a dossier is made of this, and this. That is what I know. So you're telling me what I know already. What am I supposed to tell you after that? Even at some point now, the company pharmacist, because he was also part of that interview, he even started giving me pointers on what I should say inside the interview, you know. Of course, I didn't get the job. It was a whole 1 hour that I will never forget. I'm sure I left there and they thought, oh my God, this girl has just wasted our time. But the thing is, even the theory part of it for regulatory affairs, for example, is not taught at any university, unless I'm mistaken. So why is that the case when we know this is actually a pharmacist role? And then now, because we have already identified that gap, what is it that we can do even now post-training? We normally have a lot of CMEs on asthma, on hypertension, on diabetes. Why can't we also start having continuous, not even just a one time, we just start having continuous education on these important aspects that pharmacists can actually engage in, regulatory affairs. With the current tarmacking that young pharmacists are currently going through, you'll find that most of us I am still young, not like Anita. So you'll find that most of us will actually not end up in a hospital. Most of us will find ourselves probably in an industry, but I am being let out into an industry that I am actually not well trained in. So I actually have to probably pay some huge amount of money to go through some course so that I can stand a chance at an interview. So why can't we incorporate that into our curriculum? Another very important aspect, for example, is supply chain. So it seems very easy until you go and meet Dr. Wahome at KNH. I remember I met Dr. Wahome at KNH. That time he was in charge of supply chain, and he asked me some very basic questions. What kind of tendering do we have? How do we tend? You know, that day he just told me, he gave me the Public Procurement Act and Asset Disposal and something act. So he told me, go home, read this, come tomorrow. And then we can start our discussions now from tomorrow, because I had zero idea. It is not taught. It is not, we do not also, you know, you can also miss it out in the training, but you also expose us in terms of practical experience. So these are things we should probably, if academia or policy, we should probably start thinking about, and then we can improve so that we also stand a chance with our young pharmacists. The other aspect is scope of practice. Maybe this is defined because when I was training in South Africa, there was a very clear line. What is it that a pharmaceutical technologist can do? What is it that a pharmacist can do? And what is it that a pharmacist intern can do? What is it that a pharmacist specialist can do? So there was a very clear line with no gray areas. So when we come to us, maybe, and I'm saying maybe because I'm not sure, maybe this is actually defined, but is it implemented? And I am saying this with a lot of passion because I have been a young pharmacist out of a job for 8 months. I have been a young pharmacist taking a salary of 20,000 post-internship because no one actually sees the value you can add to the practice. But that is not the case, because I actually don't believe that we have an oversurplus of pharmacists. We don't. We actually have a shortage. But why is it that even at the county level, we have people feeling like the role of a pharmacist can actually be substituted when it cannot? So is it that at the policy level, we are not implementing what we are supposed to implement, or is it that we have actually not defined what each cadre can do? Which in this case then beats the purpose of training pharmacists if my work can be done by a pharm tech. We all know it cannot, but we actually need to establish this, because we will not be having so many pharmacists out of employment, and the country is in need of pharmacists. The other day, a friend of mine texted me and told me, hey, Dr. Itotia, I am depressed. I've been out of employment. I finished internship beginning of 2020, and I am actually depressed. Then in my head, I'm thinking, oh, we've all been through that stage, and it's a stage that comes and passes. And depression, you see, sometimes we say we are stressed, but you use the word depressed. Then she actually told me, I am actually depressed. I am actually on depression medications. I have actually been admitted to a mental health institution. Why? Because I don't see why I had to go to school for 5 years to come here and be out of employment, or to come here and do casual work. Why is that the case when the country actually needs pharmacists? Why is it the case? Is that the case when we can just implement at policy level and say, for every pharmacy, you must have a pharmacist, or for every level, this facility, you must have 5 pharmacists, and you actually implement that? We will not be having pharmacists actually doing that. My friend yesterday, we were having this discussion, and she said that she studied with someone, and then she went to the village the other day, and that guy is actually doing boda work, a pharmacist, a doctor by training. Why? Why did I have to go to school? Why did my mother have to take me to school for 5 years for me to come and become a boda rider? Why is that the case? I would have become a boda rider even without going to class 1 to 8. That is a skill I can just learn. So why go to school for 5 years and just come and, you see? So the disconnect is so huge, and it's something that we have people in this room who can actually make a difference. That you as a person, you can choose, you even don't have to take 10 pharmacists. You can choose to just take 1 pharmacist and hold their hand. it also comes with a lot of goodwill. I've seen Dr. Monique here, and then I've remembered something I wanted to say. about him, that sometimes it's all about goodwill. So Dr. Mwaneki, I don't know if he knows this, but he's one of the most sought out employers for pharmacists. That's that if I get a locum at Dr. Mwaneki's, I would feel he probably will not pay me like the county, because probably he cannot also afford to pay me like the county, but he will also not pay me 800 shillings a day. He will, because I am telling you for a fact, we work and we get paid 800 shillings a day. And you know you can't work 30 days a month, so you work 25 days a month. You are not even making 30,000 a month. So it also comes with a lot of goodwill. That you, if you own a community pharmacy, if you're in a position of power that you can just uplift one pharmacist. If this conference has 1,000 people and 500 of us are in positions where we can be able to lift one per pharmacist, that is 500 pharmacists that are out of depression. That is 500 pharmacists that their parents will become a little bit proud, or their parents, you know, also depression will trickle down all the way from person to the parent. It's actually really, really unfair. The other part is also about rates for pharmacists. If you are to look, probably not implemented or not, but if you are to look at our dentists and our medics, they have very well defined rates on what they're supposed to earn. Like they will tell you for a medical officer, this is the minimum and this is the maximum you're supposed to pay on locum or permanent basis. If it's a consultant, it is this. If it is this level of consultant, it's this. But when you come to us, we have not defined those rates. And so you find, for example, in a hospital, in most private entities, you find that they will have a medical officer and they will have a pharmacist, and then they will pay the pharmacist half of what the medical officer is earning. We all know those two people are supposed to be earning almost the same. But you'll find the medical officer is probably being paid 100,000, and I'm saying this as a real life example, and then the pharmacist is earning 40,000. Why is that the case? So when the medical officer is out there bargaining for their package, they will have documents. They will show that actually, according to our board, this is what we are supposed to earn. But if we come for us, apart from the SRC guidelines that now dictate what public institutions are supposed to be paying us, we do not have those guidelines. Even me right now, if I am to be asked, Dr. Itotia, so how much do you charge for your radiopharmacy consultation? I will probably say $2,000 because you see, I do not have a guide. So I will say what I think is enough to make me happy, probably which is unfair to me or unfair to the patient. So why is it that we do not have that cut out line? Because that will also avoid the underpayment of pharmacists that we are seeing. That I would go to a job, and it's usually 12-hour shifts, by the way. If you get these locums in community pharmacy, like the job I had that was paying me 25,000, you go in at 8, you come out at 8. So you will not have someone doing an 8-hour shift and living with 800 shillings, because there will be well laid out guidelines on what it is that you're supposed to be your pharmacist, what it is that you're supposed to pay your farm tax. And the other cadres have actually implemented this. Why is it that we cannot actually implement it? So what opportunities do we currently have? I would say that the opportunity that I see is actually for us to do things differently. It's for me as Itotia to know that I actually had it very rough during my post-internship period, that whenever it is that I can to uplift a certain pharmacist, to tell them of certain opportunities that exist, to hold their hands, that I will actually do it. And I'm throwing this challenge to each and every one of us, that it is up to you to actually do things differently. It's up to you to hold the hand of just one pharmacist. Right now, I can see we are like 100. Those are 200 pharmacists who you probably will not give a job because you do not have a job, but you will hold them. You will tell them, by the way, there are these other aspects of pharmacy that you can practice. Like me now, I am all over. So people now probably know there is radio pharmacy. The other day, I was at Prof. Doidi's place and I met a pharmacist who is doing data science. and working for IBM. So I was, oh my God. So as a pharmacist, you can actually work for an IT company. So how did you get there? Of course, I wanted to know a lot of these things, but do we have platforms that we can actually learn that there are other things? Because we also need to know this, that there are other things outside the pharmacy practice. There are other things outside community, hospital, and industry that you can actually specialize in data science, work for IBM, and probably become one of the highest paid pharmacists in the country. That the other time at KU, we had Dr. Njoroge, who has discovered 2 drugs and they are FDA approved, you know. So this is a pharmacist, a Kenyan, actually making an impact in research. So if people like those are to hold people's hands and tell them there are these areas of specialization that are actually outside pharmacy that you can do. Because sometimes all we need is that guidance. Sometimes all we need is that person to actually tell us even that it's going to be okay, or that just hit me with the truth. It's going to be very rough, but you know, you can walk this path or you can go this way. But also to us as pharmacists who are out of employment, it's also up to you to also, one, not let our seniors down. You know, someone can also decide to hold your hand, then you decide, no, you're just going to let them down. So it's up to you to also not let our seniors down, but at the same rate to be aggressive. I will tell you for a fact that if you are not aggressive, you are actually going to complain of employment longer than everyone else is. Me, that time when I was stomaching, probably they don't even remember, I would email Dr. Daniela, who sent me an opportunity, which by that time I did not take, but I had actually taken the first step to actually tell someone that I need you to hold my hand. I need you to tell me of any opportunity that you can throw my way. I texted Dr. Luis Mashogo, I don't know if he can remember, and he actually sent me an opportunity from generics that got me a job. So it's also up to you to also be a bit aggressive and reach out to our seniors, but also our seniors. When we reach out to you as young pharmacists, I am here as an advocate of young pharmacists, that when we reach out to you as a young pharmacist, please hold our hand. Please do not see us as a burden. Please just work with us, because nothing is permanent, but at the same time, we do not want people going into depression meds. We do not want people killing themselves because they do not have employment. And all you had to do is do things differently. All you had to do is to hold someone's hand. Thank you very much. That was all.